So I leave it to Gireesh to tell us more about this case. Gireesh, it's all yours.
Good morning, good morning. Thank you very much. Welcome to rainy Bombay.
Can we have
We've
little
had a
louder?
cyclone here,
Just a minute,
so
Gireesh.
it's the last 2-3
Your
days.
voice.
Yeah,
Just a minute, Gireesh. The voice here is a little low. I'm sure the audience
yeah,
can
yeah,
hear you.
yeah.
Yeah, now we get it. Yeah, Gireesh, you can continue, please.
Yeah. So welcome to a very wet Bombay. We've had a cyclone here, and it's been raining last 2-3 days. Anyway, coming back to this case, actually I had a peripheral case, a tibial disease, but unfortunately there was a death in the family of that patient, so we had to postpone that. So we got another patient lined up. This is a Nepali man, 46-year-old. I think the presentation must be on your screen.
Yes.
He's got left upper limb digits critical limb ischemia. He says he's been having it since the last 3 months, and he had been sitting on it because we're taking some local medication in Nepal. Now he has come with gangrene of 2 fingers. I'll just show you the picture. He complains of pain and discoloration. And the Doppler, which was clinically, when I examined him, I could not get his brachial pulse. I could not palpate his axillary, so I thought it was a subclavian stenosis.
Which is often the case,
Finally, I
Gireesh,
did
right?
the angiogram. I'll show. Yeah, yeah.
With a
So I'll
smoker?
just show the hand. You can
Yes.
see the hand here. Yeah, he's a chronic smoker.
So this is what commonly
He
happens.
says he's given up since the last 2 days.
That's
What
usually
should I-
the case with most of these smokers, yeah? And we
Ah,
often see this
yeah.
subclavian
So
osteal lesion in these smoker patients, younger ones, and this looks more of an embolic, right, Ramesh? You would think these are all small emboli which have gone
I
into
think
small
so. It
digital
was
branches.
embolic, but
Yes.
yeah. But I'll show you the angio now. What I've done.
Okay.
Can you
Yes.
focus on the screen, please? No, first from the first. Okay, this was the aortogram. The subclavian looked absolutely fine, which was surprising to me.
Yes.
So I did a selective. You can see that the subclavian looks pretty okay.
Yes.
The axillary also seems okay. Proximal brachial looks okay. Here the brachial looks fine, but there were so many collaterals, I knew something was wrong below.
Right.
And here, no, show the next run. Show the next run again. No, next run. Next. No, next. One more. No, sorry. Previous. Okay, so here you can see there is a total cutoff of the brachial. That is why I couldn't feel the brachial. I couldn't feel the radial or the ulna. Now, looking at the history, it was pretty obvious that this was now a chronic lesion.
Yes.
In such a situation, there are already collaterals. He still has gangrene. So I was my way of thinking is what would be your approach?
Yeah, I mean, I will leave it to the experts here to tell us if you think something. It looks definitely chronic one. Yes, sir. Just a minute, Girish. We are kind of just
Yeah.
We're just having a small little discussion here.
Correct.
Yeah, because
No, that's the idea. So that
Yes.
there is no plaques in the entire vessel.
Yes.
For the reason I think it's an embolic problem.
Okay.
Because there is collaterals.
Yes.
I think it's an embolic chronic problem.
Right.
And we need to check in the heart if there is a source of embolus or something like that.
Yes.
And of course,
I have done an echo.
Okay. So the cardiac
and the echo is normal.
normal. The echoes are normal. The other thing that could come such a place would be a traumatic or a dissection there
Double-
with a secondary thrombus.
double
Again,
it.
something which is chronic. Obviously, yeah, Girish, you tell us your point now. So we have two things: cardiac, or there could be a traumatic.
So I'll just show you. Yeah.
Hypercoagulable
I'll show you the
state.
distal runoff also. Just show
Yes.
the previous. Go up. No, next. Yeah. I'll just show you next, please.
Yes, we can see that.
I'll show you the distal runoff.
Yes,
The radial looks pretty good.
yes,
Ulna is feeling very poorly.
poorly. Again, some
And
distal
the
thrombus.
intraosseous also is little better than.
Yes,
See, this is what the circulation at the wrist is.
yes. And few of the
And this
digital
is the hand.
branches are gone. Yeah, so again an embolic episode there.
Correct,
So
correct.
something in the brachial, again chronic, acute on chronic
Correct.
episode, and you could go in very easily with your wire, Girish. Can we see that picture that you were crossing the lesion?
No. I'll just show it to you. Just show that road map which I'd taken. No, second last. So here I'd taken a road map,
Yes.
and you see, I had difficulty.
Mm-hmm. Yes. This is which wire? Can you tell us a little more on the technique? Did you use a sheath or something?
See,
to
I
support
had
it? Yeah.
before. No. I was wanting to know whether I could cross, so that I could go ahead with this case.
Right.
So what I did first was I took a headhunter, went
Okay.
up to the regular 100 centimeter headhunter catheter H1,
Okay.
and took a Teramo and tried to cross.
Okay.
I had a little difficulty, then it looped and it went in.
Yes, we can see that very well. And that was nicely
So-
done because, this are difficult areas that you need to cross that. I think it's open
Yeah.
for the audience. If you have questions, please be free to question anything that you have.
No, I just finished what I did,
Yes.
and this 100 centimeter headhunter was falling short.
Okay.
So I exchanged with a 125 centimeter multipurpose,
Yes.
so that I could cross with the catheter, and then I could change over, put a sheath. I put a 7 French sheath now in the brachial,
Okay.
and I'm going to plasty the radial first, and thereafter I will plasty the brachial.
Okay. Okay. So I suppose you're getting this correct, and this
So
will be over a 1.4 wire. You've exchanged it over a 0.14, or you're still working on 3.5?
Yeah, no. I have now switched over to a 014
Okay.
through a 7 French sheath,
Right.
and I will plasty that whole segment with a 3 millimeter balloon
Right.
and see what the result is, and thereafter maybe upsize the balloon.
Gireesh, couple of things. What were the pre-procedure medication that you've got him into, in the sense? Did you start him
See,
on
I
antiplatelets?
had a little doubt that he was on antiplatelets
Okay.
even before he came to me,
Okay.
but he was only on aspirin, so I've added clopidogrel.
Okay.
And I had this doubt, so I had seen this patient about 2-3 days ago.
Right.
So I had put him on LMWH.
Okay. So in the audience, I mean, how do you
It's
take it?
obviously stopped.
LMWH, Ramesh, was the right way to go, or?
Yeah, I mean, I think aspirin or
Maruti.
DAPT and either IV heparin or low molecular weight is okay. That is, we normally start off with IV heparin. In our
Okay.
center.
Great. So again, these kind of protocols are necessary to see that this may be partially thrombotic or old thrombus, not new thrombus. And so heparin to begin with, if you're doubtful about the antiplatelet therapy, one can start before the procedure. Okay, Gireesh. So now, any more questions in the audience, or somebody wants to ask something here?
If you weren't able to cross, would you have considered going retrograde as well, Gireesh?
Yeah. That was my next. That was going to be my next step.
Okay. In these
But
cases,
the
where you
only
don't
problem
feel
was I
the,
was a little
the
skeptical of doing
pulse,
that.
probably roadmap would have been a good choice, or an ultrasound could have helped us come retrograde on that and use the pedal puncher set, or the mini sets that we have now, which will take a 1/4 wire across. Yes. Okay. So Gireesh, what's happening now on your side?
No,
we are seeing you are exchanging something now. Or
I was a little skeptical of doing the retrograde because already he's got ischemic limb.
Yes.
And if I stuff up that vessel,
Right.
which was the only supply was the radial.
Right.
So I was a little scared of that. I was lucky that I could cross. Is it come out?
In the audience,
So
what would
now
be you
what I'm
worried
doing
about?
is I've
Sorry. Yes, Gireesh.
No, now you want to know what I was doing. I've now got my 014 wire across, and I'm taking a tibial balloon and plasting that segment.
Okay.
I'm taking a little longer balloon because what has happened is that there is a little spasm distally.
Okay.
So what I'm doing is I'm going to plasty the entire segment in one shot.
Right. Would you be
It's
worried
a
about
3
distal
mm
embolus
balloon,
here,
3 into.
Gireesh?
Not so much because yes, theoretical possibility is there, but the way my wire went,
Right.
I think it is more chronic now, so I'm not too worried.
Okay.
That's why I think the retrograde is not a bad option.
Sorry?
Because that's why I think the retrograde is not a bad
Pardon?
option. Because if you put a 6-branch sheet, it is absolutely safe in this big radial artery. You have the possibility to aspirate after the procedure. And another option, probably, although it seems chronic, it is not a bad idea if you do this to go retrograde with just a catheter and just try to aspirate as much as possible of this lesion, because there are some thrombus that probably it will be of
Right.
good.
So you mean to say do aspiration there, thrombus aspiration?
Why not just pass with the catheter? It will do something just gathering the thrombus of the material, and that will relieve it if there is a thrombus burden in this lesion.
And what about the role of thrombolytic here, or any of those drugs?
I think here, I mean, 3 to 4 months, we don't have something that, I don't think the risk is justified and according to the benefit that we are going to have.
Right. Okay, so we have a whole lot of viewpoints here. Maybe aspiration is not a bad idea. Yes, one would think of that. And the thrombolytic obviously is not much of help, because this is more chronic now and it will not lyse. You know, normally on the arterial side, I've seen successes within 24 to 48 hours of acute closure. If you do thrombolytic, probably it works. So yeah, so now we have a catheter there, balloon dilatation of the brachial artery there. So a lot of people have now walked in, Gireesh, in the auditorium. The buses have come in.
Yeah.
I think, I mean, even aspiration, for the same reason as thrombolysis doesn't work, I also don't try to, pick that as a first choice, especially after 4 months.
Right.
But if it is, within a month, I mean, even though acute is less than 2 weeks, but up to a month, I think it is okay. We can try the thrombolysis or even aspiration.
Correct.
Perfect.
Correct.
Great. So yes, for the people who
what
just
about
come.
your
Yeah, Gireesh.
No. What about? I think Manny is there, right?
Manish is here. Yeah, Gireesh.
Yeah. So what do you think? I would like to ask him in this about now angiojet has just come in. What would be the role of angiojet here?
That's a very good question. We are using angiojet both in the periphery and the coronary for organized thrombus with very large vessels, 4 to 5 millimeters or greater, because it emulsifies the thrombus and evacuates it. So if you dilated this and found large organized clot And despite your anticoagulation, which is here, I guess you've gone from Lovenox to heparin. If you still had trouble, then that would not be an unreasonable option here with a 7 French device. We're using it in, there's several different catheters. We might use it 4 or 5 times a year, but in those 4 or 5 cases, there's nothing else that would have worked.
Okay.
So it's really for refractory large clot burden.
So here we are talking about angiojet system, which helps us to mechanically aspirate these thrombus. In fact, you do some amount of thrombolysis before, and then you start with mechanical. So the main purpose of angiojet is a mechanical thrombus aspiration that is done by Venturi effect that is there. The principle works on Venturi effect. So here, yes, Gireesh, now you tell us what's happening further.
So the result was pretty okay, but there was a little, I think it is basically spasm of the distal vessel.
Okay.
So I've just gone distally to just relieve the spasm.
Can we see those pictures,
and
the
then we'll
previous
take
one,
a
Gireesh,
proper shoot
the
and see.
post-plasty picture?
Yeah. Maruti, just can you show me the previous? See, this is the angio post.
Yes, the segment which
plasty.
we wanted to open has
Just on
opened
the
up
proximal
in the
segment.
brachial area. Very difficult area anyway,
Yeah, yeah.
because this is
yeah.
across the joint and you don't have much options there. But yes, the distal flow has slowed down, and that is what you're trying to balloon dilate at that segment. Yes, Gireesh. Any comments from
Yeah.
the audience or the...
No,
He
there is a
already-
possibility.
He already used nitroglycerin.
Girish, nitroglycerin is the...
No, I'm just giving it. I'm
yeah,
just
he's
giving
giving
it.
it now. Yes,
I'm just
that's
giving
a
it.
good suggestion. So whenever you feel there is a distal spasm that is happening during the procedure, nitroglycerin...
No,
Yes.
why I feel there is a distal spasm is I'll show you the run.
Okay.
Previous. Okay, next.
There it is
see
in the...
this
Yeah,
run.
this one, yeah.
When I'd crossed,
Yeah. Probably here you felt this won't work on
so there is a definite spasm there.
there, yeah. Distally, yeah, there is a spasm, probably catheter wire induced. Okay. So now what is
Yeah,
the state
yeah.
now, Girish? Yeah.
So I've just balloon dilated that segment,
Okay.
a low pressure.
Yes. How often you
Nicoran
all
NTG.
do balloon dilatation if there's a spasm? I mean, you've done NTG or, but then you still have a spasm there. Have you used balloon to open that segment?
No.
No, you don't. Anybody in the audience or Manish and Ramesh? Yeah.
I mean, I think sometimes resistant spasms can be relieved with a little slow and lower inflation with the PTC,
Yes.
with the balloon.
Yes. We've often done that in the peripheral, and neuro is another area that we keep on doing this. And I know it sometimes is, sounds a little funny that it's primarily because of the stimulation of the wall and you're getting a spasm and you're further stimulating it. But low pressure dilatation has helped sometime to open these flows rather than having a thrombus on. Yeah, now look at that. So
Yeah, and
after,
the other
so
thing
this is
that's-
Girish, dilatation and NTG both, right?
Yeah.
Okay.
After I deflated the balloon,
Yes.
I withdrew the balloon and then gave NTG.
Fantastic. So this
Nicoran
looks
and NTG.
perfect. So this looks really nice. And well, how is the heparin going on, Girish?
Heparin, I've given a bolus of 5,000.
Okay. Any
When I
suggestions
started.
from the audience and
So
the
now
experts here?
I've not.
Yeah, so a couple of things about vasodilators is that when you have sluggish flow, giving vasodilators at the tip of a guide catheter doesn't get it to where you need it to get. So sometimes doing a distal injection of whatever he used, here he used a calcium blocker, you see the effect. I mean, it really makes a big difference.
Yes.
But it's getting the drug where you need it, which is the distal bed, oftentimes makes the greatest impact. As far as heparin, we would check in what we call an ACT, activated clotting time, and really shoot for something like 250 seconds.
Okay.
We find that heparin dosing is so variable,
Right.
so that you know, in this case is giving it, you may have 300 or you may have 150.
Yes.
You really want to make sure you're therapeutic.
Perfect. So yeah, at this point, continuing with heparin dose is always worth it. And you've seen that various measures taken to relieve the spasm here. This across the joint is always a challenge for interventionists. And what happens in these patients is you can't use stents, especially at the elbow where there is an acute bending over there. And so you have a problem there. What about drug-coated balloons? That's a good point that I want to just make it across. The drug-coated balloons, in a case like this, would you suggest? Gireesh, your idea on drug-coated balloon, do you have it in mind or you've totally negated it?
No, I have them. I have them in the department, but I don't think this is thrombus.
Yes.
So by using a drug-eluting balloon, I don't know how it is going to help in any way.
Yeah, my choice, Gireesh, never to use drug-coated balloon in this. There's a thrombus there, and we know the drug is known to induce more thrombus, and we've burnt our fingers actually, and then we've learned
No,
this.
but I mean, of course. No, Vimal, that accepted. But okay, the most important thing is, what are we using the drug-eluting balloon for? For preventing neointimal hyperplasia.
Yes.
Here we have a chronic thrombus here.
Right.
So obviously there is no role.
Yes. So
Did you see the shoot afterwards now?
Yes, we are seeing it in the palm there. The arch is forming. Yeah, we have digital branches.
So no,
filling up.
I'll just show you the previous issue.
Yeah, so we
filling up
compare
much
both.
better previous. Okay, so now this is what it was above. There is a little bit of residual stenosis that I am seeing at the bang across the elbow.
Yes. I think it's in the next picture.
But the flow is pretty good.
Yes.
Show me the next run. So this is at the forearm, just above the wrist.
Yes.
And the next, and if you see the hand, of course he's moved his hand,
Yes.
but the washout is also much better than what it was before.
Right. Right.
So now I'm just planning that maybe the brachial segment I might use a bigger balloon and plastiate.
Okay. So yeah, we should see that what is happening in that territory, and for this worry of distal embolus in case. Yeah, Gireesh. Yeah. So for this, when you're worried about distal embolus, do you like to use filters here in these kind of patients, Gireesh?
Balloon kaun sa hai? Pardon?
Filters for preventing distal embolus if you're worried about it. I'm just putting points across, we may have these kind of devices with us and we would like to use it. Here in this case, it's a brachial territory. You may have it in the tibial territory. Would you use it with a single vessel runoff? Is there a role for a filter?
Yeah, but the thing is that it's so small an artery. The smallest filter we have is 4 millimeters. So this is, I don't think, beyond a 3 millimeter artery.
Right.
So yeah, I mean, here if it was a fresh lesion, I would have said yes, I'd use a filter.
Right.
But otherwise, I would be a little apprehensive about using it because of the size, basically.
Right. No, we've also.
But I accept the point made by somebody there that the other alternative was to keep a sheath in the radial, so that in case there is any thrombus that flies down, you can capture it within the sheath and aspirate it out. Makes sense, but I was pretty confident that I don't have to worry about this problem of distal embolus.
Okay, great.
So what I had used was a mosaic from Merrill.
Okay.
3x120 balloon.
Right.
Now I'm planning to use a 4 or a 5. What would you think?
I think I would remain with 4 as the highest level at this point where it's in the brachial. rather than doing overdilatation and then dissecting it, and then you don't have a salvage putting a stent there. So yeah, you have a comment, sir. You want to?
I was thinking, do we consider of doing something for the ulnar artery? Because obviously this thrombus is riding above the bifurcation between the radial and the ulnar. And what we can see is this is the fifth finger, which is usually supplied by the ulnar, and maybe something, because when we pass through the bifurcation, through the lesion, the ostium of the ulnar artery is compromised, and maybe we should see the initial pictures and see how big is it and whether it is worth of getting the bifurcation of the.
Okay. So Gireesh, here is a question: ulnar artery. Would you like to attempt something in the?
I heard.
Yes.
See now, if you see the initial picture, can you show the initial picture, please? Before I did any intervention, you could see a little bit of the ulna.
Yes.
Go. No. The one above. Next. Show me that. See, this is the angio.
Yes.
You could see the bifurcation, and you could see the. To me, it looked like the interosseous rather than the ulna.
Okay.
But after I have plastied the radial, I don't see that.
Okay.
So if you see the post, okay, just show me the next run, please. One more.
This is
here
a good
you
picture.
can see the ulna.
Yes.
But yeah, but I don't see it filling in the first picture. So what I am seeing in the middle is what I think is the interosseous.
Yes. That's the interosseous, and the ulnar is on the side, which is small because of poor perfusion there.
Correct.
And
Correct.
It's sluggishly going down.
Correct.
So what happens in the
now
in the
if once I
hand is you
plastic,
have the radial and ulnar looking after the hand. The digital arteries which have gone on the ulnar side, they've already embolized and closed. We won't be able to do anything with that. Those fingers will anyway fall off. You have to just maintain a good flow in the arch, and whatever vessels are, digital vessels are filling up. If you increase the perfusion there, that should be good enough to maintain the hand. And if that reduces the pain and improves vascularity, that's fair enough. So ischemic pain should go down with the single vessel opening up. So this is again a mosaic, sir, Gireesh, or?
Yeah, mosaic.
4 mm.
4.
Okay.
4 into 60.
Okay.
4 into 60.
So he got good flow through with the 3 mm. Now he wants to go with the 4 and get the maximum benefit over there. Any questions in the audience or suggestions? If you have any experience with similar cases in your practice somewhere.
So just let me throw it out, and in case if they find that you have an occlusion in the brachial artery but also an occlusion in the radial, distal radial, what would you do?
How do we handle that? Okay. So Gireesh, brachial artery occlusion as well as radial artery occlusion.
Pardon?
So two segments where you
Tough
find
call.
this.
Tough call. Roadmap, please.
Okay, so he is kind of focusing on the picture. So basically, if you have a radial as well as brachial artery, obviously brachial is being handled very well here. If there is an associated radial artery, probably I would go down there and look for the collaterals. If there are adequate collaterals with the increased perfusion pressure from the brachial, if that collaterals are good, I would leave it. It's too small a vessel to handle there. But if that is not the case and the limb is really, or the hand is ischemic, then probably I'll attempt a similar way, go down, go into the arch with my wire and try and bridge that with another balloon there. So probably I will attempt that. Aspiration, as he suggested, is a good choice when you go down there. Maybe a 6 French long guiding sheath, which is often difficult to get, but if you have a 150, a 125 catheter, then you can come from there, or you use these coronary aspiration export catheters or something to do aspirations there. We often do that in the tibial and in the leg, where we go into the plantar arches and open up those arteries. Yes, Gireesh, so this is your segment that you want to dilate.
Yeah, yeah.
Okay.
I've done a roadmap.
Right.
Negative.
For us in the peripheral, this roadmap
This
is a very
nominal
useful
pressure
tool.
is 7. Roadmap cut.
Since the limb does not move and we can control the
See,
movement of the
I'm
limb.
not going to get too
Yes.
aggressive here.
Right.
Very low pressure.
Yes. Yeah, you can see that lesion over there. There's one segment which is not really opening up, just about a centimeter from the distal
I'm
end.
only at 2,
Yes.
though the nominal is 7.
Okay. Yeah, this is just ironing out the segment there and clearing whatever little narrowing. This looks nice and big, Gireesh.
Yeah. I think we'll hold on here.
Yeah. So you want to have a prolonged dilatation here.
Correct.
That's a very...
See, suppose you had a flow.
yeah, Gireesh.
I just throw out a question to the expert panel there. Suppose in this situation you had a recoil. What would be your next goal?
Okay.
Would you put the patient through surgery, or you would think of putting one of those biomimetic, vasculomimetic stents? What would one do?
Okay. So if there was a recoil here for the experts here, if there was a recoil, what would be the next thing?
I think the result is pretty acceptable for me. Even if there is a minimum amount of recoil, I would leave it alone.
Yeah.
Okay. Experts here, would you have any difference of ideas or opinion?
No, I think the fracture of the stent is guaranteed in this bend.
Right.
So
Okay. So, Gireesh, overall, no, we should not do a stent there, whether it is vasculomimetic or anything.
Correct.
This is a very flexible area.
Correct.
We would not like to make it more rigid and have more trauma there.
Having said that, Vimal, I think this is an unmet need.
Yes.
In these types of situations, if you did have abrupt closure or slow flow after adequate balloon dilatation, there's very few options.
Yes.
And this is, I think, where some of the portfolio of several of the companies, including Merrill, of future products really is going to lend well to these unmet need problems.
Perfect. Yeah, so this is our dream just now, yes, to have something over here. We still do not have real answers, but I think I would have left the patient on a little long-term low molecular weight heparin or something, so that you don't have an acute thrombus in the next 10 to 12 days. And with that background, I think each patient should have done well. Yeah, a little spasm again at the distal end, which needs an attention, which is what will happen with these kind of balloons again and again. So,
You see, this is a. I mean,
Should I just?
Yeah, just the way he knuckled it, you see that there's a spiral dissection.
yes.
But in these vessels that are large, we accept this because we don't really have any other options.
Options here. Yes. So probably, yeah,
correct.
Gireesh, all of us accept
I
that.
wouldn't.
Yeah.
I think we'll just take one last run through.
Yes.
Do you use specialty balloons like angiosculpt or
Yeah.
chocolate balloon?
Somebody was saying.
Angiosculpt or chocolate balloon.
No, we unfortunately don't have either.
So,
Angiosculpt, I think we have, but those are for the coronaries.
yes.
But chocolate balloon, definitely we don't have.
Don't have, yeah.
Nicoran NTG.
So again, another, I think vasodilatation should be attempted. And then and then we take a run there.
The last run, yeah.
Yes. So I'm sure there's difference in attitude and approach when you look at peripheral versus the coronary. Coronary, something like this, you would not like to leave it alone. You'll have a disaster on table. But in the peripheral, we are a little more comfortable. Things go quite okay. And probably a good medication after the procedure would tide over the crisis here. Looking definitely a little better there. Just a little spasm distally there.
There is a little stasis basically. No,
Yes.
no, little stasis basically because I've got a 7 French sheath in the brachial.
Okay.
So that may be causing the little stasis.
Right.
But otherwise the flow looks okay.
This 7 French sheath, you have the shuttle, or which one do you have it here?
Yeah, no, I've got the bright tip of cordis.
Okay. Yeah.
This is a spasm, I'm sure
This is a
about
spasm,
that.
Gireesh. This
So
is
I
definitely long
given
segment
in,
spasm.
yeah, yeah. I think I'll take this last shoot.
Yes. We are all anxious to see what is happening to the arch there.
अभी हाथ बिल्कुल हिलो,
If
हाथ
you
हिलाओ
actu-
मत.
Very nice, Gireesh. That's really bright and good, and looks really good. I'm sure all of you appreciate that the flow is definitely much better and much faster now.
I think we call it quits here, right?
Yes, I think so. Any further suggestions from the experts here?
I wanted to ask, how long would you keep him on low
No.
molecular weight heparin?
No, I'll convert him into warfarin, but so as the usual protocol, we'll give him low molecular weight heparin for about 4 or 5 days, simultaneously start on warf or Coumadin, whatever you are happier with. Once the INR reaches 2, then we'll stop the low molecular weight heparin and continue monitoring his INR with warfarin.
Great. I think that was a great presentation, Gireesh.
Yeah.
That we could see.
Okay, so I'll just introduce.
Yes. Yes, Gireesh, we don't have you on the.
This is
thing.
who's assisting me is Chico Mall, who's the sister assisting me. This is my fellow with me, Dr. Pradyumna Reddy.
Yes. And where's Maruti?
So thank you all. And
I want to see Maruti again.
Maruti, just Maruti.
Oh, Maruti has been working with us for a long
That's
time.
the chief next.
Always smiling. So that's wonderful. Maruti, thank you. So that was great, Gireesh. We really had a
And,
good case, and a difficult case for sure, a difficult territory,
Thank you very
difficult
much.
disease. Well handled and a good result. Thank you again,
And
Gireesh. Yes.
unfortunately, I couldn't be there to meet Manish,
Yes.
but maybe some other day.
Yes. I'm sure
We'll
he'll-
definitely see you soon. Great
Okay.
work, really great work.
Great. Thank you again.
Yeah.
And
Thank you.